May I now invite Dr. Amitabh. He is the specialist grade 1 associate professor and in charge of Department of Radiation Oncology in CNSI. He is doing the radical radiotherapy in this part of our eastern India.
Thank you very much, sir, and very good evening. Thank you for the opportunity to speak here. I feel like an odd man out. I'm the only non-surgeon in this entire audience, so please be kind to me. My role here is to talk about radiotherapy in prostate cancer, and I realize that we radiation oncologists have been in a constant tussle with urosurgical oncologists regarding treatment of prostate cancer, the local treatment of prostate cancer. But I think it's time we forgot about that and start looking at individual cases and make decisions of the merit of the case. Having said that, I am standing between you, a panel discussion and dinner. I won't take much time. So what I have tried to do is divide this presentation into three broad parts. The first part will deal with all what we already know. This won't be a very new thing for any one of us, I'm sure. But in radiation oncology, there will be certain things that might be of interest to you. I'll try to highlight that, and that will be amongst the good to know or must know parts. There'll be things which are still issues, things that we in radiation oncology are getting to know, and I think it's important that everybody understands that there is a gray area which needs to be talked about at times. We'll spend a little bit of time there. And what lies at the horizon will be a very, very short part, because the horizon is very big. If we wanted to talk about it, that will take up the entire day. So we'll start. What do we already know? We know that radiotherapy is a treatment which involves treatment of any malignant or cancerous disease with ionizing radiation, which is basically radiation with an energy which can damage cells. It's as simple as that. Within a year of its discovery in 1995, the first patient had been treated with cancer. But we did not really understand the implications of treating somebody with radiation, and we made mistakes along the way. But over the last century or so, we have now come to a point where we better understand what the therapeutic ratio in radiotherapy is, which basically translates to what kills the cancer and spares normal tissue. And what I will be showing you in the subsequent slides is just steps towards how we got here. So 20 years back, when I started radiation oncology, 3D CRT was supposed to be the biggest thing around. And 3D CRT is very simple. It shapes your radiation beam according to the shape of the tumor that you're treating, in this case it being the prostate. And what we realized is we could actually escalate the dose to the prostate by using this technique and not increase the side effects. So that was the first major big step, and I keep telling my students, you may be talking about all the newfangled technology that you have, but remember that this is the biggest leap that we had in radiation oncology. So 3D CRT is better than conventional radiotherapy, a dose increment of about 10 gray from 60 grays to 70 grays, which made a difference in the biochemical progression-free survival. The next big leap was in 1997. And this was when intensity modulated radiation came into the picture. This was an investigational tool in a few universities in the US. It was not available for commercial use, but the importance of and the implications of this kind of treatment essentially were, you were not just shaping the shape of your radiation beam, now you were shaping your dose according to the shape of the tumor. This was the next big leap in radiotherapy, and this is what made further dose increment possible. And there are times when we radiation oncologists are criticized for being too technology heavy. You talk about only machines, you don't talk about patients. What have you done with your new machines? This is what we've done. IMRT was the first technology-driven treatment in radiotherapy which was able to improve survivals, not just biochemical progression-free survival, not just failure-free survival, but overall survival. And this increment was in the range of about 8 grays. You went from 70 gray to 78 gray, and you suddenly found that the survival had improved. So this is when we realized technology is extremely important, at least in our subject. But we have all discussed this. Prostate is not just sitting there quietly waiting for you to shoot it. It's going to keep moving all day. And radiotherapy is a treatment which is an OPD-based daily treatment, the duration of which we'll talk about in a little while. But typically it used to take about 8 weeks historically. So you don't expect the prostate to keep sitting there every day in the same position. And that's what this actually shows you. So when we start off treatment, that's the prostate, and sitting behind it, hiding behind the prostate as we call it, is the rectum. which is obviously, going to move, going to get filled with gas, stool, and so on and so forth, and your prostate is going to move out. And as you can see, that red circle there is what you thought the prostate was and what you wanted to treat. But what has happened on that day is, because of rectal dilation, rectal filling, the prostate has actually moved out, and now you're actually treating the rectum. So what do we do about this? This is where image guidance comes in, which means you image the prostate every day before you deliver the radiation, ensure that the prostate is within the target volume that you have created for radiation using your IMRT procedure, and escalate the dose. Again, begs the question, does it really make a difference? The answer is from the graph that you see on the left side. It does make a difference for most prostate cancers, but the biggest difference, as you can see, is for high-risk prostates. And that is a graph showing you biochemical progression-free survival. And the graph is so wide that this makes you beg the question, why don't we talk about IGRT all the time? Well, the answer is the National Comprehensive Cancer Network, which is our global cancer guideline, has recommended a technology for the very first time in oncology as being the gold standard or the standard of care in radiotherapy, and that is image-guided intensity modulated radiotherapy. The question is, why does it help? It helps because you are now going to escalate doses way beyond what you were able to do earlier. But then again, that begs the question, what happens to toxicities? Because radiation, as we all know, not only improves increased doses of radiation not only improve the outcome as far as cancer is concerned, but the normal tissue is also getting higher doses of radiation. So toxicity should go up, right? The answer is, if you're doing intensity modulation, you're avoiding normal tissues. If you're doing image guidance, you're ensuring that your target is being treated every day. As a result, as you can see there, the gastrointestinal toxicity and the genitourinary toxicities, at least from this paper, were much lower when IGRT was used. And this is just one more example to show you from a meta-analysis which tells you both acute as well as late GI toxicities were much lesser when we use IGRT instead of any other form of radiotherapy in prostate cancer. Now coming to hormone therapies, it's been spoken of wonderfully by the first speaker. In fact, I was stunned by the quality of the literature being presented. I thought I was sitting in an oncology conference for a bit, and we spoke about this a little while back. But the reason is, why do we combine it? Why is it not so that we give hormone therapies, finish it off, then go for radiotherapy? Why can't we do that? The answer is, hormone therapy by itself also acts as a radiosensitizer. And what does that mean? It means that increases the efficacy of radiation by decreasing the cell repair through the NHEJ pathway, that is the non-homologous end joining pathway, which is basically one of the constitutive pathways for DNA repair after damage. With androgen therapy, you're inhibiting this pathway, and that prevents the repair of DNA damage when it happens during radiotherapy, therefore making it more sensitive to radiation, therefore being a radiosensitizer. So all the studies that you've seen support concurrent hormonal therapy and radiotherapy and not sequential. So this is the reason why, and that is the clinical data. I won't bore you with the details of that. All of you, I'm sure, are aware that has given us a lot of benefit. The question that is being asked right now is how much hormone therapy? And that is a topic for probably a separate symposium. But let me just leave you with this. We are now looking at a minimum of 6 months, a maximum of 2 years. 3 years is no more considered to be something that we look at. And there is a Spanish group which has given us very, very interesting data about 1.5 years of hormone therapy. So you will meet oncologists from across the spectrum who go with 6 months, at least for intermediate, even for certain high-risk patients. They go for 2 years for most of their patients. And for the intermediate high-risk group, which is a new group, I'm sure you're all aware, they go for 1.5 years. So that's the kind of changes that are happening. So what do we know is being summarized in the next 2 slides. So please bear with me. And the first line is my surrender, is that no local therapy has proven to be more effective than the other. So it's time we stopped fighting. But I must also add here that when I see a young prostate cancer patient, young by definition, at least in India, being less than 60 years old, I refuse to give radiation to these patients. And there will be neurosurgeons in the audience who will bear with me, and probably they might have got those referrals as well. I do that because you're looking at survival going into 15, 20 years. And when you hit the 20-year mark, radiation fails when it comes to surgery, comparison with surgery. So that's the group probably where this statement will not hold true. But as we are all aware, most of our prostate patients are geriatric, and therefore probably in those patients you could choose one or the other, as the case may be. I won't go into details of the rest because most of this you already know. The last line is something interesting. That is something that you will probably also be faced with in the future. The role of adding chemotherapy prior to surgery or radiotherapy. That is still investigational. We still do hormone therapies as a standard of care for intermediate and high risk prior to starting radiation, and then interdigitate radiation with that. But there are studies now to show us that in the lethal subgroup of prostate, now the lethal is a very new concept, it is still not come into any of the guidelines. This is essentially a Gleason's 9 and 10. And this group, if localized, might benefit from neoadjuvant chemotherapy prior to going in for a local therapy, something which is still under trial, but something that you may also be faced with going into the future. Now, going into the part which I actually wanted to speak to you about is the issues in radiotherapy. What do we as radiation oncologists face sometimes in our MDTs when we have to make decisions on patients? So these are the few points. There will be many others. Lack of time, I won't probably go into everything, but very briefly, how do we manage node-positive patients? This is a question because I remember way back, there were patients who were taken up for radical prostatectomy. Before you touched the prostate, you did a pelvic lymph node sampling. You found a node positivity, you abandoned surgery. This is what in fact, I've got reference for that for radiation. But now I see even node positive patients undergoing surgery. In fact, very recently there has been a study which has been initiated by the Tata Group where they're trying to look at PSMA as being a guiding factor for deciding on nodal dissection rather than anything else. So that will be for the future. But what do we actually do for the node positive patients that we get now is a question that we ask ourselves. What about radiotherapy in metastatic prostate? Our first speaker touched upon that. I'll try to give you a little more data regarding that. Role of PSMA PET CT. Now, for us in West Bengal, in Calcutta, PSMA is accessible. You go to the US, and you'll find PSMA is one of the most difficult investigations. Medicare doesn't cover it. It is not recommended by most guidelines, and you get into trouble for asking for it. They don't even use gallium. They use a different tracer. And we keep looking at the US for data, so we don't get the data from there. And that's the reason why the TMH group has introduced the PSMA-based decision-making trials for us in India to probably help the world answer these questions. So we'll talk a little bit about that as well. Now, the concept of hypofractionation is something that is very close to a radiation oncologist's heart, because I believe this, and I hope you forgive me for saying this, every radiation oncologist actually is trying to be a surgeon. We are trying to finish our treatment in one day like you do. But we're not yet there, but we're trying to get there. And I'll show you how. And finally, proton beams, because this is something no seminar on radiation oncology completes. Today, everybody knows about it. I'll tell you a little bit more about it. So how do we manage node-positive disease? The easy answer is with radiotherapy. Because probably if you look at this subgroup, the radiotherapy data that we have, although not very robust, most of it is retrospective, most of it is combination studies and meta-analysis of trials and so on, but nothing prospective, nothing to give you level 1 evidence. But if you look across the data, you will keep getting an overall survival benefit with the use of radiation and ADTs in a node-positive group of patients. And that probably is the reason why, while going in for radical prostatectomies with a node positivity, there were neurosurgeons used to abandon the surgery and send across for radiation. So you could then ask, why don't we complete the surgery? If find node positivity, excellent, we'll send it to you for radiation after that. The reason probably why you were not doing that is because there is conflicting data in this area. There is some data which tells you that helps, and then on the other hand, there is data tells you which doesn't help. So if you're faced with that, you know that hormone therapy is definitely needed in this group, but the use of radiation, we still don't know whether it helps. So questionable, so if still would suggest if you get a node positivity, you probably ask for radiation instead of surgery, as far as data goes at this point in time. Next, what are we getting to know? Issues, okay. The next would be metastatic disease and what are the types. So you would get metastatic disease, and I'm sure most of you have seen this, a prostatic lesion with a lymph nodal metastasis with a couple of bones versus all bones involved. You're calling them both stage 4 prostates, but you know it in your heart that these two patients are not going to do the same in the future. Now, how do you quantify this? You can only quantify it if you have data to suggest that there is a certain volume of disease beyond which the prognosis changes. And thankfully, with some radiation oncology trials, we have actually now got an answer. So this has been tried in our subject for a very long time. As you can see, we have been trying to make metastatic disease into two very broad subgroups. You could ask why 2, why not 3, why not 4? Well, 2 is an easy number. It's easy to make decisions as far as 2 is concerned. So minimal, extensive, low volume, high volume. This is how we've been trying to do this. And the best example and the one with the maximum support is this. And this has already been spoken of. And this was a trial which we congratulate the UK group for, because they came up with this concept of radiating only the primary in a metastatic disease. Now imagine, how did this get through their ethical committee? Because we are never allowed to do that unless the patient is symptomatic for the primary. So that's a question even I have asked the trialists. They don't answer it very easily. But regardless, what they were able to show us is there is a 7% 5-year survival benefit with the addition of local therapy, that is prostatic radiotherapy, in an oligometastatic stage 4 prostate cancer. Now what does that mean as for the charted group? It means you have to have less than 4 bone metastasis, 4 or less, and no visceral metastasis. You keep getting these patients, and in our institute, the incidence of this group of prostate cancer patients is as high as 30 to 40%. But the question is, what is the basis of selection of an oligometastatic patient? In this study, PSMA was not allowed, and that's what is important for us. We have access to PSMA, and it's about time we started doing a PSMA to identify this subgroup. Why? Is because with the help of a local therapy which is literally non-toxic, very easily accessible in today's time in Calcutta at least, you will be able to provide your patient with 1 month of therapy and a 7% overall survival benefit. Think about that. Nothing else that you do as far as hormone therapy is concerned, chemotherapy is concerned, gives you that number with that short duration of treatment. But what about the sites of metastasis? As I just said, you have 4 bone metastasis and the prostate, and you're giving radiation only to the prostate. Why don't we treat the metastatic foci as well? Why do I say this? Because today we have the tools to ablate metastatic sites with the help of radiotherapy. And this is not very new. This has been around for the last 10-15 years. But as far as our city is concerned, we only started doing this about 3-4 years back. Today we have a wealth of data to tell us that this is doable, and this is very, very, very easy for us. It is not something that requires much training. It just requires the mindset and the ability to catch the right patients, to give them the benefit they deserve. The question is, does it then make a difference to ablate the metastatic sites in an oligometastatic prostate cancer? The answer is, we don't know. There have been 2 studies. The only difference that we see when we ablate metastatic sites versus not ablating metastatic sites is to delay androgen therapy, and that's it. Nothing else seems to matter. So this is still not something we usually routinely recommend or do, but definitely institutional practice, like in my institute, I have recommended this for select group of patients, not everybody, but we do it when we get the opportunity. Now, as I promised you, role of PSMA PET-CT. And this is something I tell my students. Just because you have a hammer, not everything you see is a nail. So just because you have access to PSMA PET-CT, you should not just jump in and do PSMA PET-CT everywhere. So the question that I get asked in return is, why not? The answer is, you have to look at the benefit that a PSMA PET-CT gives a patient when you prescribe it. So by doing a PSMA PET-CT in a group of patients, did you improve their survival? Did you decrease their toxicities? Did you change any treatment protocols? The usual answer is no, but the no is on the basis of studies done in countries where PSMA PET-CT is very rarely done. So it is upon us now to take the data, and I'm sure everybody in this audience has prescribed PSMA PET-CT. So please take it upon yourself to collect and keep that data. Maybe someday we can pull it down and come up with a publication which might make a worldwide difference. But what do we have till date? We have multiple studies telling us that they have been used in the surgical setting, in the radiation setting. But the problem is, we still don't have the data to give us gold standard evidence to be able to make this the most important investigation in prostate cancer. And the reason is there may be concerns about inappropriate or overuse. Just to give you an example, a low-risk prostate cancer patient who does not have anything else, is an incidentally detected patient, does not require a PSMA PET CT scan. But sometimes they do undergo it. At times they don't undergo it. We have to make that decision as to when you need it and when you don't need it, and the guidelines are not very clear about this. But there is an ongoing study in the UK which will probably answer this question in the future as to when and where exactly a PSMA PET CT will help a prostate cancer patient. Now, as I told you, we radiation oncologists want to become surgeons, but probably haven't succeeded till date because we can't finish our treatment in a single day and let the patient go. But we are trying to get there. How? Because initially when we started radiation, we used to keep calling our patients back with prostate for about 2 months. 5 days a week, 40 days of treatment, so 2 months. What we subsequently realized is that's just too much, and the patients also used to get extremely irritated towards the end of their treatment, regardless of whether they had side effects or not. So the next thrust was to try and decrease the overall treatment time. Instead of 2 months, let's make it a month, probably make it 5 days, and so on and so forth. And these words, hypofractionation and SBRT, are essentially our attempts towards doing that. As a side note, most radiation oncologists have, at least in the US, have been accused of being money makers because they are the richest oncology community there. And why is that so? Because the money that they earn depends on the number of days of radiation they give to their patients. There is no package system there. So if you take 5 days of radiation, you get X amount. You take 10 days, 2X amount, and so on and so forth. So imagine the amount of humanity that they have showed by actually allowing the treatments to become smaller. So this is something we congratulate the Americans for, because there are many things good about them, very many things bad about them, but this is one of the good things I think we can learn from them. And the fact is, moderate hypofractionation, which is basically finishing an 8-week treatment in 4 weeks or a maximum of 5 weeks, is at least the same as doing a longer course treatment. This is the one-word answer or one-line answer to the question, how does it differ or how does it compare to normal radiotherapy or what we call conventional radiotherapy. So there have been many studies, non-inferiority, superiority, and all of them keep telling us the same thing. It is as good as conventional radiation and as at least as toxic or as less toxic as conventional radiotherapy is. And taking all this data together, our American parent body, which is the American Society of Therapeutic Radiation Oncology, has recommended 2 protocols. This is now the standard of care in prostate. If you get a patient who has been treated with 8 weeks of treatment, please understand they probably are not being treated with the recommended protocol of today's day and age. And that protocol, as you see there, 60 grays in 20 fractions or 70 gray in 28 fractions, are the 2 protocols that are now routinely used everywhere. There is no 8-week treatment anymore. Our institute has completely given up on long course radiation. We generally do 60 and 20, and I'll show you what we are doing next. This is what we are doing next. So stereotactic body radiotherapy. What does that mean? It basically means you increase the dose of radiation being delivered per day and decrease the time even further. So between 5 to 8 days of treatment and you're done. This used to be considered investigation. In fact, in my slides, I will not show you the recent change in guidelines because that is something we radiation oncologists hotly debate. There are 4 trials and there are many criticisms of those trials and many supporters of that trial. So that is for a radiation oncology audience. I won't show you that. I will still mention that it's under trial at present. We have preliminary data. We have Indian contributions, and this is from our friends in Tata Medical Center, who are basically running an arm of a study being conducted by TMH Mumbai by Dr. Vedang. And they have come up with very interesting data. Vedang was recently feted by the Astro for coming up with this data. And so this is something that we are now proud of. We Indians have started hypofractionating and doing SBRT for prostate probably even more than the Western people. And I'm happy to say that at CNCI we are doing it on a routine basis, and our results are probably comparable to what we have been seeing in the West. So the pros and cons would basically be, the prostate is a very slow growing disease. We all are aware of that. Even untreated prostate cancers can live for years. Because it is slow growing, the amount of cell kill that you can achieve with a dose of radiation is very strongly dependent on how much radiation you're giving in a single day. I hope I could make myself clear, because this involves a lot of radiobiology which I don't want to go into, but it is basically that. So if you increase the dose per fraction or the dose per day, theoretically you should get a better outcome. Why we were not doing it till date was, by increasing the dose per day, you were also giving a higher dose to the rectum and bladder. With the help of IGRT, IMRT, image guidance and so on, we have now been able to decrease that dose, and therefore that is now a reality. So SBRT is something that will become the standard of care going forward, and within our lifetimes we will see 5 days of radiation, and I dare say someday 1 day of radiation being equivalent to 80 days of radiation, and that's the day when I can come and say we've done what you people have been doing all this time. And finally, the new kid on the block, probably proton beam therapy. No seminar on radiation oncology please complete without it. So why protons and why are they so interesting? Because we all know about electromagnetic radiation. Light is electromagnetic radiation. One of the properties of electromagnetic radiation, you cannot stop it unless you have lead, a very high Z metal or element in front of it. There's nothing in your body which is that. So it's going to go through and through your body, maybe deliver a higher dose to the region that needs the dose, but everything around it will also get some dose. That dose is never going to be zero. And radiation is a stochastic effect, meaning the effect of radiation starts from any dose above zero. There is no safe dose in radiation, and we have a principle called ALARA, as low as reasonably achievable. So proton is the only system of radiation because it involves particles, and the particles show you this phenomenon called the Bragg peak. So if you see that red line there, that is the dose deposition with depth. And at a particular depth, you can see that there is a sharp fall, almost like a precipice, going down and becoming zero. You will never see that with that black line, which is photon or X-ray based radiation. And this is the beauty of protons. This is the reason why everybody now wants a proton. Why aren't they not getting it? Because it costs $200 million and 2 lakhs a day to run. So very few centers will be able to afford it. But if you can afford it, probably it is something you should have. But is it important in prostate? Till date, no. Single line answer, no. Till date, nothing that you have done with proton has actually made a difference when it comes to prostate cancer patients. There are pediatric patients who benefit, there are brain tumor patients who benefit, there are recurrent cancer patients who benefit, but when it comes to primary prostate radiotherapy, you will not do any better by sending a patient to proton, except maybe make them spend about 10 times of what they would have spent in the city. Now for radiation oncologists like us, this is what we started radiotherapy with, and this is brachytherapy. But because brachytherapy is more of an art than a science, and the new technology that we have makes us sit at a computer and do the treatment without having to run around and do anything else, this is a dying art. But I'm proud to say we have started brachytherapy for prostate cancer at our institute. In fact, the first case in India with a new brachytherapy system is going to happen tomorrow, and I want all your good wishes and blessings for that to succeed. So brachytherapy is essentially this. I won't bore you with the details. What it basically means is you go through the perineum with the template, put in needles, give the radiation, and that's it. You take out the needles and the patient goes on. And as I promised you, very short slide on what lies at the horizon. Now a few days back, I had gone for this International Radiosurgery Symposium, and one of our colleagues from the US actually showed us a very interesting slide where he shows us a gas bubble coming from the colon, going down the sigmoid, then through the rectum and then leaving the body. This is while radiation is ongoing. So what then happens is, your prostate is sitting there, the radiation is being delivered, the gas bubble comes, it completely moves out, and your rectum gets fried. But how did we get to see that? It's not possible with the systems that we have. That's the answer. This is known as the MR-Linac. This is already installed in India. The first installation was in Hyderabad. Very soon they're going to have a few more in India. And this is probably the future of prostate radiotherapy. The MR-Linac will probably replace all the existing systems when it comes to delivery of radiotherapy in prostate. And finally, something which is going to affect everyone in this audience, machine learning and artificial intelligence. It's already come into our subject. This is the flow chart of the machine learning AI trial that is currently ongoing with various kinds of omics being used to make treatment decisions. So this is the conclusion. Technology is something that has helped prostate, it's helped us, and the innovations in technology as well as in the other forms of oncology are actually helping prostate patients. So thank you very much. I'll be happy to take questions.
Thank you, sir. Any question? So if there is no question, we are